Welcome to the Cholangiocarcinoma Foundation's webinar, especially today on World Cholangiocarcinoma Day. I'm so excited to introduce. We have two distinguished experts in cancer immunotherapy joining us for this important discussion. Our speakers have dedicated their careers to advancing T-cell-based therapies for solid cancers, bridging the gap between laboratory research and clinical application. And personally, I'm so grateful for their work because it has definitely saved my life. First, we have Dr. Simon Turcotte, a surgeon scientist from Canada, whose expertise spans solid tumor immunology and cellular immunotherapy. He serves as an associate professor at the University of Montreal and as an HPV surgeon and scientist at the Center Hospital of the University of Montreal, or CHUM. His work focuses on tumor-infiltrating lymphocytes, TIL therapy, for hepatopancreatobiliary cancers, and under his leadership, CHUM is one of the only two centers in Canada offering access to TIL therapy through clinical trials. He also directs a cutting-edge cell and gene therapy clinical research program and one of Canada's largest HPV cancer biobanks. He's also the C3 star clinical lead for the Canadian Cholangiocarcinoma Collaborative. And joining him is Dr. Eric Tran, an associate member at the Earl H. Hiles Research Institute at Providence Cancer Institute in Portland, Oregon. Dr. Tran earned his PhD in biochemistry and immunology at the University of Victoria and trained under the world-renowned Dr. Steven Rosenberg at the National Cancer Institute, where he contributed to pioneering adoptive T-cell therapies targeting cancer mutations. His current research focuses on understanding why these therapies work in some patients, but not others, intending to develop next-generation gene-engineered T-cell therapies to improve patient outcomes. Together, Dr. Turcotte and Dr. Tran bring a wealth of knowledge and experience to the field, and we're eager to learn from their insights. And most importantly, they are the primary reasons I am alive today. I cannot thank them enough for dedicating their careers to research. I just want to remind everyone that you can put your questions in the chat or in the Q&A box, and we will have an open Q&A discussion at the end of our presentation. And to please try to keep your questions general in nature. They won't be able to give personal medical advice. So keeping those questions general in nature will help us to get those questions answered. And I am going to turn it over to Dr. Turcotte. He will start us out today.
Hi, everyone. It's really a pleasure to be with you today. And thank you, Melinda, for the kind introduction. Can you hear me well? Very good. So I will be delighted to present an introduction to cholangiocarcinoma and where immunotherapy fits in the treatment scheme. We're just going to wait a second for the slides to come up in presentation mode. So thank you, Melinda, for the introduction again. And if you can advance one click, this is what it looks like this morning. So it's really pretty in summer out here. But in winter, it has a different flavor. Before, these are my disclosures. So to start to speaking about bile duct cancer, biliary tract cancer, cholangiocarcinoma, I think it's important to state that they're not all the same. As you can see here, and you probably know on this diagram, bile ducts are within the liver and they're getting bigger to make the bile travel to the GI tract. And the cholangiocarcinoma can really start on any bile duct cell. So it can be intrahepatic to start with, and it becomes like a large mass in the liver, but it can also be perihilar or more distal towards the small bowel, or bile duct cancer can also arise in the gallbladder. And this is important because it dictates the treatment strategy for one thing. But if you show the next slide, it is also important because the molecular nature of cholangiocarcinoma is very distinct, whether this cancer has started within the liver or outside the liver. So this is a very busy slide, and I will just highlight some aspects that I think are important. let's look by cancer location, starting with the gallbladder on the left side of the screen. The risk factors are slightly different than for intrahepatic or extrahepatic bile duct, but more importantly, the molecular features opens possibilities for targeted treatment. There are some genes that are overexpressed, amplified, like ERBB2, for which nowadays there are some molecules and treatments that target ERBB2. Iridia1 is also another one. The gene mutations I have highlighted in bold are those for which we have targeted treatments nowadays. If you look at the intrahepatic molecular features, you will see that the mutations are slightly different. These tumors are slightly molecularly different, and one of the best known target for cholangiocarcinoma now is the FGFR2 fusion mutation. And I'll go back to this a little later, but there are some target agents that are quite potent targeting this mutation. And extrahepatic cholangiocarcinoma also is a little bit of a mix of the most frequent mutations found in the gallbladder or the intrahepatic cholangiocarcinoma. So one of the things that the foundation has been telling patients and Melinda is you need to get to know your cancer, where it is, and also what is the molecular profile to get a sound and the best treatment options possible. So to move on, next slide. The way clinician sees, evaluate, and decide on the treatment scheme for a patient with cholangiocarcinoma goes a little bit along those lines. This is very summarized, but the important concepts are there. If you have a tumor that is located in one area and that is amenable to surgery or sometimes liver transplant with very strict conditions, then the standard treatment obviously is surgery, is to cut this tumor out. And the question you have to ask your physicians and oncologists are, is it worth it to do 6 months more chemotherapy, adjuvant chemotherapy, to reduce the risk of this cancer to come back? There may be, you have to be on the lookout for clinical trials in this adjuvant setting that could use novel immunotherapies, and we'll get to that in a few slides. Next slide. If the tumor is more advanced, there's no surgery possible, or it has started to send metastatic tumor deposits outside the liver or in other areas of the liver to the lymph nodes adjacent to the liver, then what is very important is to first stay fit. Second, this cancer, as you know, comes often with blockade of the bile ducts, so jaundice can be an issue, and this needs to be managed very properly from the beginning in a high volume center with good expertise in managing jaundice in the context of cholangiocarcinoma. And then you need to obtain the molecular profile and discuss your treatment plan and with a multidisciplinary team, and hopefully have access to a molecular tumor board. If the cancer is really widespread, one needs a treatment that's going to go everywhere in the body. It's going to be administered intravenously. So standard chemotherapy plus immunotherapy now is the first-line standard of care, and I'll get to more details about that. Targeted therapy against the mutations I've highlighted also are very appropriate. However, they're more approved as a second-line treatment nowadays. If the tumor is really localized, even though one cannot remove it surgically, there are quite effective liver-directed therapies that are warranted to discuss with your treating physicians. But I don't have time to go into the details of that. If this strategy in the green box doesn't work, then it's time to look for investigational approaches, immunotherapies, and other. Okay, this background said, now let's get into the very fun part. You can click on the image here to see a lymphocyte that's gonna find a cancer cell and destroy this cancer cell. I don't know if the video can be activated. Yeah, on the play button. So T cells patrol the body. They infiltrate tissue. They infiltrate tumor. If you just get rid of the pointer, I think you may be able to play it. And those T cells, we have 1 million of T cell per ml of blood. They can find abnormal cancer cells and perforate their membrane and send into the cancer cell some enzyme that's going to destroy the cancer cell. This is in a dish in the lab, but that's the type of effect we want to induce with immunotherapy clinically. Next slide. What are those T cells recognizing at the surface of cancer cells that can mediate the treatment effect, that can kill cancer cell? There are many possibilities, but one that you will hear a lot about is called neoantigens. Those are small parts of proteins that are derived from the mutated genes, which are characteristics of any solid tumor. Those mutated peptides, neoantigens, they reach the surface of cancer cells, and T cells, immune T cells, recognize those peptides as foreign, and that's what triggers the attack of the cancer cell by T cells. And this is really the mechanism by which we've been able to help Melinda fight this disease. Is it common that neoantigens be recognized by T cells? Perhaps one of the best evidence has been found by the NCI and the group of Stephen Rosenberg. Mariah Parker's here in this table. You can see in the majority of cholangiocarcinoma, bile duct cancer tested, she could find some neoantigen reactive T cells, as well as in other GI cancer. Next slide. So based on this, how can we leverage, how can we potentiate with a therapy this immune attack, this T cell attack of neoantigens on cancer cell? There are three main approaches. The first one I will talk about are cancer vaccines. There has been more interest in recent years to re-explore cancer vaccines as a side effect of the COVID pandemics. mRNA vaccines have been proven to be very effective, and they can be used in the context of cancer. And usually those vaccines have to be injected in several doses, and they really train the T cells to recognize antigens. And we can now engineer those vaccines, those mRNA vaccines, to express neoantigens and prime one's T cells to recognize neoantigens expressed by cancer cells. Next slide. We believe that the efficacy role of adjuvant vaccine is probably best when there is minimal residual disease in the context of adjuvant therapy. We don't have yet good data for cholangiocarcinoma, but I think it's important to keep this on your radar that there will probably be some trials of mRNA vaccines following resection of cholangiocarcinoma at high risk of recurrence. Because we have those examples in melanoma and in pancreatic cancer now, that this treatment can be effective in preventing the recurrence. On the left, you have the melanoma example of a large phase 2 studies of 157 patients. They underwent surgery for melanoma, receive mRNA vaccines encoding neoantigens, and there was this reduction in 44% risk of cancer recurrence or death. And this is leading to a larger phase 3 trial for melanoma. To the right, you see the feasibility proof of concept study that was recently published for pancreatic cancer, a cancer that is really close in essence to cholangiocarcinoma. That was only done in 15 patients. We have to be very cautious about the results of that small study, but nonetheless, encouraging results are showing that patients who had an active immunization against the neoantigens didn't recur after 14 to 18 months of follow-up, and this is leading to a larger phase 2 randomized control study. So I think these approaches are valuable if you're in the situation where you are undergoing surgery for cholangiocarcinoma. You can look at whether there are some trials investigating the role of adjuvant mRNA vaccine after resection of cholangiocarcinoma. Next slide. The main type of immunotherapy you've heard about is called immune checkpoint. This is therapy by which we try to reinvigorate those T cells that are infiltrating the tumor and try to recognize neoantigens and to kill cancer cells. Those neoantigen reactive T cells expresses inhibitory receptors, breaks. PD-1 is the most well characterized. CTLA-4 in blue here depicted is another one. And I think if you click on the slide, you will see those ligands that are expressed by cancer cells or macrophage. They can bind to CTLA-4 and PD-1 and inhibit the function of T cells. So if we click again on the image, you'll see the role of immune checkpoint is really to prevent this to happen, to leave the T cell the freedom, if you may, to attack and the full function to attack the cancer cells. Next slide. This has been proven more effective than standard chemotherapy in cholangiocarcinoma patients in the recent years when targeting PD-L1 or PD-1 in combination with gemcitabine and cisplatin. You can see the results of the two largest studies. On the left, the TOPAZ studies. On the right, the keynote study with the anti-PD-1 antibody. And you see that the median overall survival has been improved by roughly a month and a half in those large cohorts of patients in favor of patients receiving chemo plus this immune checkpoint targeting PD-L1 or PD-1. So small progress, but still a significant improvement in overall survival combining standard chemo with anti-PD-1. But as you see, still it's not sufficient, right? We want cure, we want a better effect. And even if you start on the first line of chemo plus anti-PD-1, PD-L1 therapy, you need to think about the next step, because most patients will recur and progress within 1 year of initiating this type of treatment. Next slide. So what's next, right? If this is not the greatest option, there are some chemotherapy, standard chemo novel combination after progressing on first-line therapy that are associated with roughly 6 months of median survival after first-line treatment. Perhaps more interesting are, if you click once, more interesting are targeted treatment, especially the FGFR2 mutation. If the first line doesn't work, then what you see here is the median overall survival of patients who've received this targeted therapy against FGF2R, and you see these overall survival numbers are more encouraging. Other targets also leads to significant response rate and are certainly valuable to receive if one has this mutation. We click again. There are multiple immune checkpoints and combination of immune therapeutic antibodies has also yield interesting response as second-line treatment. The best response is highlighted there. I would close this very busy slide by saying that one needs to keep in mind that there is infrequent but important marker of the immune recognition of cholangiocarcinoma, which is the amount of mutation, the tumor mutational burden, and the mismatch repair gene protein deficiency. It's less than 3% of cholangiocarcinoma that has this molecular feature, but the majority of patients that has this type of alteration will respond to anti-PD-1 therapy, and this is approved in the States, in the United States, and in Canada. I think if you're seeking for a clinical trial and you don't have an actionable mutation in your tumor, that looking for combination immunotherapy, combination of immune checkpoints with chemotherapy, radiotherapy is certainly valuable because these are synergistic, but you also have to keep in mind that combining combining immunotherapy can also lead to more toxicities, and we need to be very cautious about new symptoms and weird symptoms, and quickly report to your physicians if you find something is not going in the right direction. Okay, I want to touch a word on where this is going. Immune checkpoint therapy for other cancer is being given after surgery with curative intent and has shown positive signal of improved survival. And this is probably going to be tested in cholangiocarcinoma in the future. And then next slide. I've talked about vaccine, I've talked about immune checkpoint as new immunotherapies. T-cell transfer immunotherapy is going to be very well covered by Eric and is the third general type of immunotherapy that you need to be aware of. So to close, I want to remind everyone that the development of solid cancer immunotherapy is certainly promising. But bile duct cancer finds many ways to escape the immune recognition. We need to continue research to improve cholangiocarcinoma immunotherapy. You need to get to know your bile duct cancer, where it is, what's the distribution, what's the molecular subset to have an adequate treatment plan, and see what all your options are. Obtain expert opinion in high volume center. This is a relatively infrequent cancer, and the management is very peculiar. I talked about jaundice management, for instance. And the molecular aspect of the tumor also is the analysis of this is available in larger academic high volume centers. Obtain targeted therapy if you can. Try to take part in clinical trials testing immunotherapy as early as possible in the treatment plan. It's rare that salvage immunotherapy, it's less frequent that salvage immunotherapy can work, but obviously it's not impossible. And Melinda certainly can certainly testify on this. Try to stay as fit as possible and attempt multiple sequential and combinatorial treatment approaches, which are more likely to be effective on the short and long term. So thank you. This is what I wanted to share with you today, and I'll be happy to answer any questions.
Thank you, Dr. Turcotte. And again, to the audience, if you guys will submit your questions in the Q&A and the chat, I see some are coming through, keep them coming. And we will get to Dr. Tran's presentation, and we will do questions at the end of the presentation talks. So Dr. Tran, you are up next with your TIL therapy, a groundbreaking approach.
Just hopefully you can hear me. I'm just gonna pull up my slides here.
Yes. And while you're doing that, I'm going to just ask Dr. Turcotte one question. Can you expand on staying as fit as possible? Does this include exercise and nutrition?
Yeah, it does. So really, the more fit you are, I think the better you can support any form of treatment. The best nutrition has an important role for the immune system function, and also spiritually. If you're one person that is all stressed out, is not probably going to have the same outcome as someone who can manage feeling about what is going on and be counseled on this front as well. Even though it's less obvious to show scientifically, I think it's an important component.
I agree. Thank you. Okay. We'll get back to questions at the end.
Okay, sorry for the delay. Hopefully you can see my screen now. Okay, excellent. So good afternoon, everyone. Thank you, Dr. Turcotte, for the kind introduction. So today, I'd like to provide a background on what adoptive T-cell therapy is, with focus on tumor-infiltrating lymphocytes, or TIL, and on kind of next generation of adoptive cell therapy approaches as we try to develop more effective therapies for cholangiocarcinoma, among other solid tumor types. So here is my disclosure. So I know Dr. Turcotte had mentioned a lot about T cells, and I just wanted to take a step back and kind of define for the audience what a T cell is. So T cells are a type of white blood cell in our bodies that protects us from things like viruses and bacteria. And so I've just put a cartoon here. It's a very simplified cell. All of us have billions upon billions of T cells within our body. And one of the unique features about each one of these T cells is something called a T cell receptor. So this right here. So even though we've got billions upon billions of T cells, each one of them has a different T cell receptor, which makes it unique. And this uniqueness is actually very important because it allows that one T cell to recognize a very specific virus or bacteria, for example. And so how does a T cell really recognize its target? So let's just give an example here. So this is a cell, let's say it's a cell within your lungs. And let's say, unfortunately, a person is infected with a flu virus. So the flu virus will gain entry into, let's say, the lung cells of the lung. And within the cell, it's going to start replicating. But as part of the defense, natural defense in your body, the cells will start breaking down this virus within the cell. And in doing so, it breaks down the viruses into what Dr. Turcotte had mentioned, proteins and peptides. And so these will actually be flagged onto the cell surface, as shown here. So this blue viral peptide or protein gets flagged onto the surface here in the context of this, what we call MHC or HLA molecule. And so this is important because this is not part of our body. It's a virus particle. And so now the body is like, okay, we're flagging it. This is not normal. And then again, out of those billions of T cells in your body, you'll have some of them that have the right receptor that kind of fits this like a lock and key. And so once we can see this, once the T cell receptor can see this virus peptide or protein, then it can initiate a killing response to control this virus infection. So this is kind of a very general mechanism of how a T cell can protect us from things like viruses and bacteria. But why am I telling you about viruses and bacteria? Well, it turns out that in patients with cancer, there are, some T cells in the body that have the right T cell receptor that can recognize cancer cells specifically. And with that background, this is why, a lot of us are pursuing adoptive cell therapy. It's in a type of immunotherapy where immune cells, such as these T cells, are removed from a patient, grown and manipulated in the lab, and then reintroduced back into the patient. And the rationale behind this is that the infusion of a large number of tumor-reactive T cells will be able to overwhelm and eradicate the tumor cells. Currently, there are really two major types of adoptive cell therapy. And so the one I'm going to focus on first is using tumor-infiltrating lymphocytes, or TIL for short, as a therapy. The second type is really using T cells derived from a patient's blood. But what we do is we genetically engineer those blood-derived T cells to express receptors that can target the tumor. One of these receptors, you've already heard about the T cell receptor. So if we can find a T cell receptor that can recognize a cancer, we can use that. There's another class of receptor called chimeric antigen receptors, which has had really good success in blood cancers, less effective in solid cancers. That's something I'm not going to touch on today, the CARs, but we can certainly address that if anyone has any questions in the Q&A. So the first type of adoptive cell therapy I'd like to talk about is using TIL, or tumor-infiltrating lymphocytes. And this is really pioneered by Dr. Steve Rosenberg, who unfortunately cannot join us on this webinar today. But he was really the pioneer of deploying this sort of therapy in humans. And so this was done in the 1980s. And it's really highlighted by this cartoon here. So a tumor is resected or removed from a patient. This tumor is then taken into the lab, where they're essentially cut up into small fragments. And these fragments are put into this culture dish. Each one of these round balls here you see are T cells. And so what we can do in the lab is we can provide these cultures with factors that can drive T cells, that will drive T cells to grow. And this factor here is called interleukin-2, for example, or IL-2. And so within weeks, we typically get millions of these cells, and then we can select some of these cultures and then expand them to billions of cells. So we go from, these millions to billions, and then these billions of T cells are infused back into the patient. And so this type of therapy, TIL therapy, has been most studied in the setting of metastatic melanoma, which is the deadliest form of skin cancer. And I just want to highlight some of the lessons that we learned. So I think first and foremost, TIL therapy can be curative. And so in patients with metastatic melanoma, so cancer that's spread, overall response rates can be about 50%, and about 20 to 25% of these responses can be durable, long-lasting, and cure. So some of the initial patients that Dr. Rosenberg treated out 20 plus years, right? And they have no evidence of disease. This really led to the FDA approval in just 1 year ago for the use of TIL therapy in metastatic melanoma. And so I know that, a picture is worth 1,000 words. And so I just want to highlight an example here. This is a patient, 29-year-old gentleman with what you can see, a sizable, looks like a tennis ball size metastatic melanoma in his neck. He had spread to his lymph nodes. And then the TIL were growing up as I described in the previous slide, where we took the tumor fragments. Dr. Rosenberg's group took the tumor fragments, grew them up with high-dose IL-2, and then infused them back to the patient. And you can see here's even just 12 days after treatment, you can see this huge tennis ball size melanoma shrink, and for this patient disappear, and he experienced a durable, complete response from this therapy. So this really I just wanted to highlight the power of what these T cells can do under the right circumstances. So another lesson from TIL therapy and melanoma was actually highlighted by Dr. Turcotte. So it turns out that TIL that recognize these mutations known as neoantigens, as Dr. Turcotte mentioned, likely played a major role in these clinical responses. And so again, just striking home the point that Dr. Turcotte mentioned, cancer cells are not normal cells, and they're not normal because they've got changes in their DNA or mistakes in their DNA. They're called DNA mutations. And some of these mutations can be essentially translated into a protein that has a mutated amino acid. So a very small change usually, but it's different. It's not normal. And just like a virus can get bits of its protein exposed on the cell surface, this mutated protein can actually be also exposed on the cell surface of this tumor. So this is now a flag saying, hey, look, this cell's not normal. And if in most patients, as we've observed, the patients have T cells with the right T cell receptor that can usually recognize, at least some of their mutations expressed by their cancer. And again, through this interaction, then this T cell can now destroy the cancer cell. And so while metastatic melanoma is deadly, the majority of cancer-related deaths are due to cancers derived from the epithelial lining. So very common cancers like colorectal cancer, breast, lung, etc. And so we really want to investigate whether we can harness these mutation-reactive TIL in order to mediate tumor regression in these patients. And so really, I'm really going to highlight this point by describing Melinda's case, right? So Melinda was the first patient with an epithelial cancer, cholangiocarcinoma, to be treated with TIL targeting a unique mutation. So Melinda had metastatic cholangiocarcinoma with the standard type of treatments, chemotherapy. So Dr. Turcotte, while he was at the surgery branch NCI with Dr. Rosenberg, he initiated this clinical trial to test TIL therapy in the setting of patients with metastatic gastrointestinal cancers. And so for Melinda, they were able to generate about 42 billion cells. And then those were infused, followed by 4 doses of interleukin-2, which is that T cell growth factor. And so retrospectively, so after the infusion, we actually studied her infusion product. We found that about a quarter of all the TIL, the T cells in that infusion product, targeted a unique mutation expressed by Melinda's cancer. And it's a mutation in a protein called ERB2IP. And so here are kind of some CT scans of what happens. So pre-treatment, you can see these masses are not supposed to be there. This is our lung CT, and you can see those masses. After 7 months after transfer, you can see some of them shrank, and some of them have shrank substantially. Similar results were found in the liver. You can see these dark areas are tumor, and you can see them shrinking after the adoptive transfer of TIL. If we kind of quantify this using a graph, so this graph is really just looking at how big the tumors are here on this axis, and then the time before and after cell infusions. So you can see before cell infusion, the TIL infusion, the tumors were growing in the lung and liver, and then on day 0, the cells were administered. You can see that there's disease stabilization for about a 12-month period, at which time the tumors did start to grow again. So we asked the question at this point, can we do better? And so armed with that, that information that her initial product had about 25% mutation-reactive TIL, we asked, well, can we increase that percentage and maybe deliver more cells? And so we studied that product a little bit, and we found out that that initial T cell product we gave Melinda was made up of 5 different cultures. So you remember that cartoon I showed you with the different wells of T cells. So Melinda's product was made up of 5 of those wells pooled together. When we kind of look back at each one of those, it turns out that there's one culture that was really highly enriched in this mutation-reactive TIL product. And so we selected just that one TIL culture for therapy. So after expansion, we found out that about 95% of all the TIL were reactive against a mutation. And the cell manufacturer team was able to generate a larger number of cells. So instead of the 40 billion, this time it's about 120 billion. And again, so we had a higher number of cells, but also a higher frequency of these mutation-reactive T cells. And after infusion, you can see in October 2013, you can see these large, bulky lung metastases. This is 2 years later of the scan. You can see that they have shrank substantially. Some of them actually disappeared. And so this really was the first evidence that we could potentially harness this mutation reactive T cell response to mediate regression of these difficult to treat cancers. And again, this is quantifying the effect of the cell therapy. Again, this is essentially how much tumor was in Melinda here. And this is the time after the first cell infusion. So I showed you this already. So tumors are growing, first infusion, and then a year later, they start to grow again. And then here is where we infuse the second product. Again, 95% were reactive against the mutation. And you can see this precipitous drop in all her tumors here. And you can see this time around, it lasted about 3 years, this response. But you can also see that there was a slow progression after about 3 years. And so the question for us became, well, why did some of these tumors progress? And can we give Melinda another effective treatment? And so the next slide I'm going to show you is probably the most busy slide. And so I just want to warn you, but I'm going to walk you through it so hopefully you can understand it. So the next slide is really, the main purpose is to track the frequency of the reactive cells that we gave Melinda. So essentially we want to see, do the cells persist in her over time, or do they disappear? And maybe that's why the tumors are coming back. Okay, so again, here's a busy slide, but on this axis, I want to tell you that this is how much, or the frequency of the mutation reactive cells present in Melinda or in the infusion products. And here's just, again, the time course. This bar here was the first infusion product. So about 25% were mutation reactive in the infusion product. Anything in red is the mutation reactive T cell in the blood. So you can see after infusion, we see a high frequency, and then it kind of drops over time to about 0.01%. We resected progressing lesions, and you can see within the progressing lesions, between 1 to 10% were of the T cells within the tumors were the mutation reactive cells. This was a second infusion product, as I mentioned, 95% pure in terms of reactivity. And then you can see in her blood, much higher frequencies over time. So even at 3 years after her second infusion, about 3% of all her circulating T cells were the mutation reactive cells. So remember, I mentioned each one of us has billions upon billions of T cells in our body. So 3% of many billions is actually still a lot of T cells. And intriguingly, here are her tumors, some of the tumors we resected when she was progressing. Over 50% of all the T cells within her progressing tumors also were mutation reactive. So what this tells us is that, the tumors are growing not because the T cells aren't there. The T cells are there in very high numbers, right? So probably billions upon billions of these reactive cells are still there, but they're progressing for some other reason. And so I don't have time to get into some of the things we did, but it has to do with some of the things that Dr. Turcotte mentioned, right? Immune checkpoint inhibitors. And so we thought, Melinda has billions upon billions of these reactive cells. Can we just maybe reinvigorate these cells with an immune checkpoint inhibitor? So that's what we did. We gave her anti-PD-1 therapy, and you can see in her lungs, you can see the shrinkage of this disease. Again, this is 3 years out. So this is after, before anti-PD-1 and then 3 years after anti-PD-1. You can see this lesion has disappeared. And so she had complete regression of one lesion, and the other lesion shrank substantially and has remained stable to this date about 8 years after anti-PD-1 therapy. So again, this is, I just want to highlight this case because it really strikes home the point that these mutation reactive T cells in the right settings can be quite effective against these cancers. And so there are other cancer types that are being tested with experimental TIL therapy. And so here I've just listed some of the cancer types. So when I say bulk unselected TIL, that means essentially the first generation TIL approach, which I showed my first slide, where we take the tumors out, grow out the T cells, and then infuse them back to the patient. What we did for Melinda was really kind of the next generation, where we try to select for more mutation reactive cells. This has been attempted for breast and other gastrointestinal malignancies like colorectal, et cetera. But I think the reality is that, outside of melanoma, TIL therapy is rarely curative for patients with most types of these metastatic epithelial cancer. So while there's hope and promise, we see that it can clearly work in some patients. a lot of patients do not experience cures. And that's what we're going for, right? With this T-cell therapy, we're hoping that we can cure these patients. And so really, I'd like to kind of jump into like, well, how can we improve like TIL therapy and other cell therapy strategies for these types of cancers? So in order to do that, we have to have an understanding of maybe why they're not working optimally, right? So why is it not working? So one hypothesis is that the frequency of the tumor reactive cells within TIL is highly variable, and the TIL infusion products may not contain a high frequency of desired tumor reactive TIL. And so I can highlight this by just using a cartoon. Again, this is a tumor mass that we might resect from a patient. All these colored balls are different T cells, but maybe only the purple ones are tumor reactive, right? So these other ones, the orange and the green ones, are what we call bystander T cells, and they don't recognize the tumor. They're there, they're not helping at all. If you expand the T cells within this, what you get is expansion of all the cells, right? And a lot of the times, these tumor reactive purple ones could be essentially outgrown by these orange and green non-reactive ones. So in a lot of the TIL studies that I showed you that use bulk TIL, this certainly can be a factor where the frequency of reactive cells is not sufficient to mediate meaningful tumor regression. And so how do we get around this? Well, so this is a cartoon that I pulled out of Dr. Turcotte's recent review article just published last month that highlights a potential strategy to enrich tumor reactive T cells for therapy. So remember, the kind of first generation approach is just growing out all these T cells and using them for therapy. What we can do now is essentially take this tumor, make a single cell suspension, and then we can label the cells that are tumor reactive, the purple ones, and we can physically isolate these away from the non-reactive ones. And we do this through technologies like called flow cytometry or fluorescence activated cell sorting. And this is a way to essentially, again, physically enrich or sort these purple cells in this case away from the other cells. Once we have that enriched tumor reactive cell, we can expand them to high numbers and use them for therapy. And so this is something that my colleagues here at Providence are actually exploring. So my lab is helping them with the manufacture process, growing these cells for patient treatment. And so I'd like to highlight one patient that had actually undergone this sort of therapy. My colleagues here are Dr. Andrew Weinberg and Dr. Brendan Curdy. They've got this clinical trial that is testing whether if we can directly enrich these tumor reactive TIL, can that mediate tumor regression? And so this is a patient, AGX03, patient with metastatic melanoma, progressed through radiation therapy, high-dose IL-2, and 3 different immune checkpoint inhibitors, so highly refractory to current and experimental therapies. What we did was we took the tumor, did the single cell suspension, and then what we did was we physically isolated these tumor-active TIL. And this is jargon, I know, for most of you, but these are the markers or the receptors that we use to sort, to essentially identify the reactive cells. So any cell that expressed these markers, we plucked out using that technology, and we plucked out 68,000. So I just want to keep that in mind. Like, you know, I'm talking about millions and billions of cells, but in this case, we're plucking out 68,000 cells. And then we're expanding them up, and we got 7 billion cells after this expansion. So this is like 100,000-fold expansion, which is quite remarkable. It kind of tells you like how robust these T cells can be. And so we infused it into this patient. And so this is a scan. I just want to orient you in terms of what you're seeing. And so this is actually a leg. You're seeing the patient's leg. This patient had lymph node disease and subcutaneous disease, so in the skin, extensive skin disease. So the way to look at this is like, if you imagine someone lying flat on their back and you look directly through their heel or their foot and you do cross sections of the leg, you're seeing essentially the white is the bone and then our surrounding tissue. And so this is what we call it. It's actually a very enlarged popliteal lymph node. And then here's, again, the subcutaneous. It's all riddled throughout the skin of this patient. And then after the 7 billion T cells, you can see that this is 7 days after TIL therapy. This has normalized in size, and then you can see all the subcutaneous masses have essentially disappeared. And so this patient currently has no evidence of disease about 1 year after cell infusion. So again, demonstrating another example of the power of TIL. And in this case, about 68,000 TIL that were originally in the tumor expanded to 7 billion. So This could be a strategy to enhance TIL therapy. It's just really to select for the ones that we think are reactive at the beginning. So another potential reason why TIL therapy might not be effective is that the functional capacity of these TIL might be suboptimal. So although in some cases I've shown you, TIL can be sufficient to mediate regression of all this metastatic disease, the reality is a lot of these TIL have been in the body for a long time, probably in the tumor for a long time, could be years. And in doing so, they're fighting the tumor, they're getting older, and they're getting potentially exhausted. Right? And so how might we overcome this? Well, this is just kind of the life cycle of a T cell, right? So we start out as kind of younger cells, what we call naive or TN cells. And they essentially, like humans, we get older and older, right? But T cells kind of get older as well. And they differentiate, we call it, into these T effector cells, for example. And what you need to know here is that throughout this kind of aging process of the T cells, we find these cells more often in TIL, right? And whereas we know that these can mediate regression disease, in mouse models, if we transfer these older cells versus the younger cells always do better. So you can see that, sorry, I forgot to mention, this is anti-tumor activity. So how well they can clear tumors in mouse models. These ones don't do as well as these ones. So is there any way we can harness T cells from the blood instead of TIL? And so one strategy involves gene engineering. And this is called T cell receptor or TCR gene therapy. And it's called gene therapy because we're going to genetically insert a T cell receptor into T cells. So again, the way this works is we would take peripheral blood from patients with the younger T cell populations and then genetically insert this receptor into the T cell to redirect it towards the cancer, right? And then we can expand these T cells and infuse it back into the patient. And so this sort of strategy, again, uses cells from the blood, which can potentially contain younger, potentially more effective cells. We can make a high frequency of these tumor reactive T cells. We can use receptors that we know are really good at recognizing cancer cells. We don't require surgery. But the challenge here is that it's limited to targeting tumors that express a specific mutation and HLA molecule. So it has to do with the biology, but this receptor is very specific for a specific peptide in the context of this MHC or HLA molecule. So you need to match on the antigen or the target. Essentially, the target has to match, your tumor has to express a target, and the tumor has to express the correct HLA. So in practical sense, what that means is like if you have a patient population, only a small subset of those patients will be eligible for a given receptor because of these limitations. And so, you know, getting a receptor and genetically inserting a T cell and giving it back to the patient, I know probably that sounds kind of outlandish to a lot of you, but it's actually, you know, has been done for a little while. And in my lab here in Portland, we actually did it several years ago to target a mutation in KRAS called KRAS G12D in a patient with pancreas cancer. So similar to cholangio, a very deadly disease with very little effective treatments. And so this was published a couple of years ago now in the New England Journal of Medicine. So the patient I'd like to highlight, patient with a 71-year-old female diagnosed at 67 with pancreas cancer, underwent very standard chemotherapy followed by a Whipple resection, which my colleague and friend, Dr. Turcotte, does very routinely. She had bilateral lung metastases in 2019. She actually was treated with TIL therapy, but had growth of tumor 6 months later. So her tumors expressed the target that we wanted to go after, KRAS G12D, and also the other part I mentioned, MHC or HLA. She had the right HLA. And so we initiated a single patient IND to treat this patient with this TCR gene therapy approach, where we genetically insert the receptors into her peripheral blood T cells and use those for therapy. So we manufactured 16 billion cells and infused them into the patient. And these are the results in the CT of the chest. So this is looking at an X-ray of her lungs. I'm highlighting 3 lesions here in the arrows. And then at 3 months and 6 months later, you can see that these lesions have shrank substantially. So she had overall 72% reduction in her tumors at 6 months. unfortunately, the response lasted for 1 year. So we were unable to cure this patient with TCR gene therapy. However, this provided kind of proof of concept that even in pancreatic cancer, this sort of genetic approach could mediate tumor regression. So it provides hope that we're on the right track and potentially we could improve this therapy. So really the summary points here is really that the adoptive transfer of TIL or TCR engineered cells targeting mutations can mediate regression of metastatic epithelial cancer, including cholangiocarcinoma and pancreatic cancer. It doesn't work for many patients, and therefore improvements are needed. I didn't get into this, factors that impact adoptive cell therapy or tumor heterogeneity. This is something like if you have a tumor mass, it's actually not the same throughout the tumor. So these differences or heterogeneity can be a challenge. Other features that may impact cell therapy efficacy is the functional capacity of the T cells. And of course, the tumor is actually quite a hostile environment for the T cells. And so with that in mind, I've highlighted, a couple of strategies that might improve adoptive cell therapy for these cancers, but there are a lot more different strategies to really enhance cell therapy that are being explored by, our groups and others around the world. And so here's kind of my summary slide of what folks are doing out there in terms of trying to enhance cell therapy. Can really be divided up into directly enhancing the T cells or TIL directly, or we can combine the TILs with other therapies by administering drugs or other therapies that can help the T cells. So from the directly enhancing TILs or T cells part, so I mentioned we grow out the T cells and we give them back, but I didn't really describe how we do it. And there are many ways you can do it. So depending on how you grow the T cells with different cytokines are proteins that T cells respond to, there are dozens upon dozens of different cytokines. And so depending on which cytokines you use, that can give you a different T cell product. And so we believe there are certain cytokine cocktails, as we put it, that can make better T cells. So that's one way to improve T cells. We can genetically insert or knock out genes. So we can, for example, genetically knock out PD-1, right? So PD-1 seems to be important for putting the brakes on T cells. And there are groups that are exploring genetically knocking out inactivating PD-1 in these T cells. On the flip side, we can overexpress or knock in genes into the T cells that hopefully can enhance their function or proliferation. And as I mentioned, the blood T cells might be in better shape than TIL. So in that strategy where we try to harness the tumor reactive T cells from the tumor by looking at certain markers, we could potentially do the same thing in the blood. The challenge there is that in the blood, there are a much lower frequency of the tumor reactive cells in the blood. So usually like 1 in a million. But, my lab and others around the world, we're trying to figure out, that 1 in a million, that 1 in a million tumor reactive cell, do they look different than other cells around it? And if so, we can pluck out those 1 in a million cells, expand those blood-derived T cells and use those for therapy. So that's another way we could potentially enhance cell therapy. So layered on top of these cell therapies, we can administer drugs to the patient. So classically, host lymphodepletion has been used, which means that we temporarily wipe out the immune system of the host so that once we transfer T cells, they have the best chance for survival and mediating tumor regression. We could administer cytokines like interleukin-2, but there may be others. Dr. Turcotte talked about immune checkpoint blockade, co-stimulatory molecule agonists, things to put on the gas pedal in the T cells, vaccines. We can remove things that shut down T cells. So we know that there are certain cells within the body that can shut down T cells. So we can potentially remove those. And we can actually target the tumor themselves, right? So, there are drugs, small molecule inhibitors that could target the tumor. So potentially if we hit the tumor itself, we can essentially, for lack of a better word, weaken the tumor, kill some tumor cells. And that might make it easier for the transfer T cells to then kill the tumor cells. So these are some strategies that we and others are pursuing to try to enhance cell therapy. And the final 2 slides are really just demonstrating or showing you that there's a lot of active research in TIL and TCR gene therapy. This slide just looks at some TIL clinical trials in the US for solid cancers. Here I've shown what type of TIL When I say bulk TIL, it's really the first generation growing out the TIL and then giving them back. Tumor types here, patients are treated with IL-2 in this case. In this case, IL-2 plus checkpoint inhibitors. And then here's kind of the next generation where we're kind of like knocking in or knocking out genes. So I'm not going to go into details of these genes, but essentially trying to knock out negative regulators of T cells, or putting in something that T cells like, interleukin-15 should cause proliferation of these cells, knocking out PD-1, et cetera. And this trial here is the direct enrichment of tumor-reactive TIL. And these are the different tumor types that are being investigated. Here's the trial number. And similarly with TCR gene therapy clinical trials, there's a lot of active research in this area. And you can see here are the targets that are being targeted with TCR gene therapy. For example, a lot of KRAS mutations, P53 mutations, KRAS mutations, more KRAS mutations, and also cancer germline antigens. I didn't get into that, but there are different targets that we can go after with TCR gene therapy, and then trying to enhance those T cells with IL-2, or in this case, again, we can knock out negative regulators or overexpress things that we think can boost the T cell function. And here are the different tumor types and the trial number. So again, the main limitation with TCR gene therapy, the patient has to kind of match on two molecular fronts, really the target expression and also the HLA, as I mentioned. But again, these two slides were really meant to show that, again, lots of active research in trying to enhance or boost adoptive cell therapy using TIL or TCR gene therapy. So with that, thank you for your attention. I know that might have been a lot of science, so hopefully you guys could all stay awake. But with that, I'd like to hand it over to Melinda, and afterwards, I think we can get into Q&A.
Yes, that was amazing. Dr. Tran, I'm always so impressed, and I'm going to definitely have to steal these last two slides and make sure that I see that there were already questions in there about maybe sharing slides if we're okay to do that. I am going to make an executive decision, and I'm not going to do my presentation because my presentation is out there widely, and I think most people know my story, but I really want to get to some of these questions, and I'm afraid if we don't get to them, we won't get them answered. So if I have time, I will come back to mine, but I really, really want to do questions if that's okay with you guys.
Sure.
All righty, so I'm going to just start at the beginning. And feel free, whoever wants to jump in, or both of you. If cancer detected only after has spread stage 4, how can you know location for targeted therapy? This is from the first couple slides, Dr. Turcotte, that you did.
Sure. Well, we cannot biopsy every lesions. We know that there are some sampling errors. One, usually to start to identify what we call truncal mutation is a very good start to get a treatment plan. If it doesn't give you the answer you want, a second biopsy makes sense for another lesions.
Okay. Let's see. Do you have suggestions on where to get expert opinions for cholangiocarcinoma in high volume centers inside Canada? How would people look? Yeah, how would people in Canada know where to go for second opinions from experts?
Yeah, you can look at whether there is a hepatobiliary and pancreatic surgery team in a hospital, or a dedicated team of oncologists that treats pancreatic and bile duct cancer is a good indication. And in most large academic hospitals, you will find this in the large Canadian cities, Vancouver, Toronto, Montreal, etc.
Okay, thank you. All right, how can you test your tumor to understand the type, amount, or sensitivity of neoantigens on the cell's surface? Put another way, how can you test how potentially successful TIL therapy would be for a patient?
Eric, do you want to tackle this one?
Yeah, sure. I think, that's a really important question. And it's something that, we could actually spend hours on talking about, especially with the nuance, right? So at a very practical clinical kind of level, right, Dr. Turcotte had mentioned something called TMB, or tumor mutation burden. And so that is something that is kind of a proxy, right? So they can do genetic sequencing of your tumor and estimate the amount of mutations that the tumor expresses, right? And by proxy, the more mutations you have, the more potential neoantigens you have. thus the more likely you'll respond to immunotherapies like checkpoint inhibitors, right? And so I think that's probably the high level answer that I'd give you. I think, we could dive deeper a little bit in terms of, well, that's genetic testing, right? So, but that doesn't necessarily translate to like the amount of neoantigens that are actually expressed by the cancer cell. To actually get at that question, we actually have to use very cutting edge technologies that are based on something called mass spectrometry, that we can actually then start looking at that HLA molecule and then taking off the peptide and then identifying how much of that neoantigen peptide is actually expressed by the cancer cell. But that's actually like, ongoing cutting edge type research that people are trying to do, is understand, these neoantigen peptides, how much is actually on the cancer cell, because you'd ideally want to be targeting those with the highest expression of those peptides to, have the best chance of success. So I know it's just, we could spend a lot of time on that, but hopefully that high level answer can suffice for now.
That sounds good. That was pretty good. Okay. What is the difference between FGFR and EGFR?
It's two different proteins that have different function for a cell. So completely different targets, completely different treatment implication.
And are you aware of anything that's been done with FGFR3 mutation target?
There are some FGFR blocking agents that will work for different fusions, different receptor of that large family, and efficacy is under study. It's still unknown whether FGFR3 can be targeted as well as its little brother, FGFR2.
Okay. If one immunotherapy becomes toxic, does that mean other immunotherapies will be off the table? I think that's a good question. We get that a lot.
Yeah, it's a very good question. The short answer is usually for clinical trial, when there was a severe adverse effect to immunotherapy, it's considered as a big red flag and exclusion criteria. But it's to be discussed carefully from patient to patient and what type of reactivity exactly it was. And it's not black or white for any given patient.
Okay. The next question is there currently any clinical trials for T-cell for cholangiocarcinoma, and what is the exclusion criteria? But I think I'm going to steal your slides, Eric, and I will be able to share for that question. Okay. Okay, I'm going to hold on that one. Can TIL therapy be looked at as a treatment that reduces tumor burden and potentially opens someone up to resection or transplant?
Well, it has never been studied in this context. There are anecdotal cases where progression after TIL therapy was followed by immune checkpoint inhibitors, and there was some good response, like in your case, Melinda, but I don't think there's sufficient data to say that this is a generalizable approach that's going to work. But I'm not aware of any transplant or surgery for curative intent post-TIL done on a routine basis. I think on a case and patient basis, it could be justifiable as a general approach of treating oligometastatic disease. There is one residual tumor, it makes sense to resect it, but it's not necessarily a generalizable treatment plan.
That's good. Okay, Eric, how both of you envision AI enhancing and advancing T-cell therapy?
Yeah, that's a good question. Yeah, AI definitely is in the news a lot these days, and certainly from a scientific perspective or research perspective, I think a lot of folks are trying to figure out how to best deploy or use AI to help their respective research areas. I can give you maybe like one example related to T cell therapy that might be tangible, right? So in the trial that we're trying to select the tumor reactive T cells from the TIL, right? We're basing it on a few different markers that I mentioned, right? But it's possible that, we might be missing some reactive cells, for example. And so if we study more of the TIL and we can find more reactive cells from different patients, and then we can study how they look like, right? We have a large database of these cells where we know that are tumor reactive. We kind of know what they look like compared to the T cells in the tumor where they're not reactive and we know what they look like. That potentially we can use AI to kind of sort out what are the markers that best kind of can pick out those tumor reactive T cells for use for therapy. So I would say that's more kind of again, I guess a tangible use of AI, but the limitation there is a database, right? So in order for this to be actually to work, we need a large data set of T cells that are truly tumor reactive compared to T cells that are really not tumor reactive. And then once we have that big database, then we can kind of use AI to sort that out. But that's kind of one example. I don't know if Simon has another example.
Yeah, I think in selecting patients more likely to respond to immunotherapy or other treatment, AI is going to be useful more and more in the future as those database increases in size, and as we can also combine data from the tumor genome, the microbiome, and all different sorts of variables that are linked to patient outcome.
Okay. Does the location of the primary tumor matter for TIL therapy in cholangiocarcinoma? Would patients with distal cholangiocarcinoma be candidates?
As of yet, there's not enough patients treated to respond, with certainty to this question. But TIL is an approach that can be applied to any solid tumor. What makes this therapy work is when you harvest that tumor where there's some tumor reactive T cells that are fit enough to be expanded and that will, then mediate the response of the treatment. And again, it's potentially applicable to any type of solid cancer.
Okay. Eric, what was the time frame for growing those cells? The example was the 68,000 to, I think you said 7 billion. What's the time frame to grow those cells?
Yeah, so for that particular example, it's the 68,000 directly sorted cells to the 7 billion. It was in the time frame, it was between 3 to 4 weeks, so less than 1 month.
And is that about average? I feel like, how long did it take to grow 1 billion cells? For me, I felt like it was about the same time, maybe. I don't know.
So I think there's a type of research that's called like process development in our world, right? Where it's essentially trying to figure out fine-tuned parameters of how to grow cells. For your particular cells, Melinda, I went through two-step process, right? Where we just took the tumor fragments, grew out with high-dose IL-2 for about 2 to 3 weeks, and then we took aliquots and repped. So it's a rapid expansion for 2 weeks. So I think for your process, actually 4 to 5 weeks, if we just, went straight from start to finish. But obviously, there are clinical considerations in the meantime. And so by the time you got your cells, it's more than 5 weeks, I think. But I think we're at a point where TIL therapy can certainly be viable in terms of cell manufacture in the 3-week range. Is something that we hope we can get it down to for that sort of therapy.
Okay. The next question was, can TIL therapy be used for METs to the peritoneal? And I think the answer is it can be used for METs anywhere in the body, right?
Sure.
Yeah.
Okay. So Melinda had the ERBB2IP mutation that was reactive. What other mutations have you found reactive in various studies being done?
Yeah, that's so I think that's alluded to in Dr. Turcotte's part of this talk, where he flashed up a table from Mariah Parkhurst and Dr. Rosenberg's lab. And I think the key take home is that almost all of the reactivity is personalized, right? So like if you take 100 patients and you look at reactivity of the TIL to mutations, it's going to be unique to that patient's mutation because like there are very few shared mutations between patients, right? And so, I mean, in terms of the number of mutations that have been recognized, I mean, it's certainly in the hundreds that the NCI have found in terms of T cells reacting against mutations. And if you go across the world, it's thousands. But it's really just has to do with the patient's own mutations and reactivity against that. We find it's very rare to find shared reactivities, except for KRAS or P53, where some patients you can find shared reactivities, but that's quite rare. Yeah.
So tell me if I'm saying this right, because this is what I say, and I
Yeah.
could be completely wrong. But I always tell patients that it's not necessarily about the mutation you have for this therapy. It's more about your immune system recognizing that mutation.
Yeah, certainly from my perspective, I think that's a that's a fair comment, because we know that not all mutations are immunogenic. Immunogenic just means like in some patients we don't find T cells that target a specific mutation. So it's
Gotcha.
really, you need the best of both worlds, where you have the right T cell receptor or T cells in your body that can respond to a mutation that's expressed high enough in that cancer, right? So that there can be that recognition. So yeah, and so the majority of mutations are probably not immunogenic, actually. So it's just those few handful that can drive a T cell response.
Okay. In regards to trials for TIL therapy, are these trials available outside of the US and Canada? Do you know, are they being done globally?
So currently, I don't think there is a cholangiocarcinoma specific trial sponsored by the industry. There's an academic trial in the US. Help me, Melinda, it's at Penn.
UPMC. Mm-hmm.
Yeah. And we're working on opening one here in Canada before the end of 2025. There are some targeted T cell therapy approach that can recruit cholangiocarcinoma patients. And again, Eric, I think, made a nice summary of that.
Yeah, I guess generally, I think like China is also really large into cell therapy right now. So if you look at T cell receptor gene therapy, and even I think TIL trials, I think there are certainly some available there. Again, I don't know the tumor indication, like if it's cholangio or other tumor types, but I mean, if you just look at the cell therapy space, China's actually the very large one, and probably has more cell therapy trials in the US in general.
Okay. So TIL versus TCR, if there was a choice for entering into a trial with a solid tumor with both of those, what do patients look for? What would be the better choice? If there is one.
That's another hours long conversation, I think. In the history of TIL therapy is longer than TCR gene therapy, I would say. It would depend on a lot of factors, like the tumor type, right? The tumor type, the mutation profile. TCR gene therapy is a little bit restricted right now, right? As I mentioned in the last slide, there's only a number of targets that can be pursued. So by default, if your tumor doesn't express those targets, then you do not be eligible for TCR gene therapy, unless you go highly personalized. And there's only one place I know doing that. That's the surgery branch NCI with Dr. Rosenberg. It's just, yeah, there's just too many factors to kind of just say like one or the other on this question. But yeah, TIL therapy has the advantage of being agnostic to everything. It's just the TIL are from the patient. You can grow them up. If you can find the right ones, it will be for that patient. Again, TCR gene therapy is very selective.
Okay.
Yeah. So Simon, I know
I know it's so hard.
It's just worth a longer discussion, I think.
But as you showed your patient, right, did TIL first and then TCR?
Yeah.
Yeah.
That's right.
Okay.
6 months response for the TIL and the 1 year with the TCR, but it's hard to really compare those
Right.
two. Yeah, so.
Okay. Abscopal effects of radiotherapy or other ablative techniques, are they linked to an immune response?
We think so. There's no better explanation So that's for the one who don't know what abscopal effect is using radiotherapy to target one tumor and observing shrinkage of metastases outside the field of what was irradiated. And so we think that the tumor that has been destroyed by radiotherapy has led to antigen presentation to the immune system, to T cells, and that those immune cells traffic and travel in the body and that kill other cancer cells.
Yeah, so I think that field it's a very interesting field. I think as of today, I'm not aware of like really hard data that shows that abscopal effect is present in many cases, right? So I think there's anecdotal cases of that happening. Again, as Dr. Turcotte mentioned, radiate one tumor and then the other tumor that's not radiated goes down. But those are very anecdotal, and it hasn't been really reproducible like to a certain degree. So I think it's very interesting if we can leverage that, obviously. But today in humans, it's yet to be really investigated thoroughly enough to know if it's a true effect.
Okay. Somebody asked how I feel post-treatment. I feel amazing and I'm so grateful. I have a great quality of life. My biggest complaints are from the chemo that happened before the cell therapy. But yes, I feel amazing. The great thing about the TIL therapy is it's a one-time treatment. So it definitely gives your body a chance to recuperate and not have side effects all the time. Though I know that there can be side effects, and but I've been very fortunate not to have any long-lasting side effects, and I definitely have an amazing quality of life, and I'm so very grateful. Okay, so for TIL therapy, do you need tumor tissue or can you use blood that has tumor cells in it? And I think you discussed that.
Sure. Yeah. For TIL therapy, you do need viable tumor source in order to extract the viable T cells from that. So, but as I kind of alluded to in the kind of last few slides, we are certainly interested in trying to find these blood TIL, as it were, right, for lack of a better term, TIL that have been in the TIL but maybe escaped or maybe on the way to the tumor, and try to pluck those out from the blood to amplify. But again, the major challenge is that in TIL, it's probably a 1 in 100 T cell or greater, right, in terms of reactive cells. 1 in 10, 1 in 100 that are reactive. In blood, it's 1 in a million, right? Because you've got all these T cells in the blood that are there because they're poised and ready to recognize different viruses, et cetera. And so finding those cells and enriching them to meaningful levels is the challenge. But that's something that, again, we and others are working on.
Okay. So as a surgeon and then as the research you're doing, Dr. Tran, for patients who have resection, what is going on out there for like growing the TIL from that resection to be prepared for a recurrence, to maybe use it for treatment at recurrence?
Simon, you want to take that?
What?
You want to take that one, Simon? Yeah.
Sure. That's a very interesting concept and largely unexplored, right? To do standard surgery in a patient for a tumor that is at high risk of recurrence and banking this tissue for further use as TIL therapy if there is a recurrence. I love the idea and the concept, and I think it should be developed it should be really developed, because we also start to know that the earlier the immunotherapies and the TIL therapy treatment is, the better the likelihood are of mediating a response. And so it's a very good idea in a concept that is worth pursuing, that has been understudied as of yet.
So we need more trials. Okay. If response can be poor if you have a low TMB, can anything be done to create having a high TMB? Because that actually sounds bad to have a high TMB, but it sounds like responses are better when you have a high TMB.
Yeah, so I'll give my thoughts on that. I think, there are researchers out there that are actively trying this approach where they're administering chemotherapies that we know are kind of mutagenic to increase the TMB. I think, the risk to that is that you're creating additional mutations, right? And potentially increasing risk for other cancers as well with this sort of approach. So I would say that that is an interesting idea that some researchers are pursuing. I think that becomes a challenge because the type of mutations are important too, right? Because I mentioned in one of my slides, like tumor heterogeneity is important, which means that if you have one tumor mass, some cells here, some cells here, they'll have different mutation profiles. And if your T cells only can see one mutation expressed by one subset, then it's going to touch the others. And what these chemotherapies or mutagenic agents do is it's more heterogeneous. They're not delivering a clonal mutation. It's like some cells get this mutation, some get this other mutation. So I think there's a potential risk there. But again, it's interesting and there are researchers exploring that.
Okay. Can we talk a little bit about the side effects and the risks of doing TIL or TCR therapy?
Yeah, Simon, you want to take that?
Sure. The major side effects are caused by the lymphodepletion regimen. As you heard from Eric, there needs to be those 5 to 7 days of chemotherapy to remove the already existing T cells, circulating T cells, neutrophil, white blood cells, temporarily to create space for the new effector T cell to proliferate, to find their target. And so this lymphodepletion has adverse effects. It's going to cause alopecia, so loss of hair. It's going to cause some nausea, some fatigue, but it mainly also increases the risk of infections because temporarily your immune system is shut down. And there is a fair number of bacteremia and infection in the week following the lymphodepletion that needs to be treated aggressively with antibiotics when this happens. And it's very rarely fatal, but it's a risk associated with this therapy infection. Regarding the immune-mediated side effects, it's very infrequent that TIL will cause autoimmunity. In melanoma, TIL can target melanocyte antigens and cause vitiligo, depigmentation of the skin. In the GI tract cancer patients we've treated, I think there was no significant such autoimmune effect. The cells that are used for TIL therapy have already been selected in the thymus by the immune system not to react to the self antigen. For TCR therapy and CAR therapy and gene engineer therapy, this can be a more significant issue because we're trying to get the best TCR and the best T cell as possible, the more potent, but there could be some normal peptides that really look alike the cancer antigen and peptide, and there can be some off-target effects that certainly has been reported in the first iteration of that approach, and it constitute a higher risk. So immune-related toxicities is a higher risk for TCR engineered T cell, in my opinion.
Okay. I got a couple questions and then we'll call it because we're at time. Could you talk about dendritic cell therapy and how that differs from TIL?
Eric, do you want to go ahead?
Sure, yeah, I can tackle this one. So dendritic cells are another type of blood cell in our body. They're known as antigen-presenting cells, or APCs. And so their main function in the immune response is to kind of amplify T cell responses. So they can take up targets, the tumor or antigens, other antigens, and they can display these targets to the T cells and really enhance their activity. One of the first immunotherapies that was approved was really from Dendreon as a dendritic cell vaccine in the setting for prostate cancer. where they essentially took dendritic cells and then put some prostate cancer antigens targets onto them, and then used that for therapy. And it showed some activity, although it wasn't overly effective. So, in the last 5 or 10 years, like most of the cell therapy focus has really been on T cell based therapies or NK cells, for example, and others. But there's still some research being done in terms of dendritic cell therapy, because again, like T cells are different types of dendritic cells, and maybe people are trying to explore these different dendritic cell subtypes in terms of can they be more effective at eliciting T cell responses against tumors.
Okay, you guys, there are an awful lot of questions that we didn't get to. So if it's okay with Dr. Tran and Dr. Turcotte, we will gather all those questions and email them to you. And hopefully you can help us answer some of them, and we'll get the answers either posted on the recording of the website in that area, or when we have access to, we know who the question is, we can email them back the answers. But there was an awful lot we didn't get to, so I apologize to everyone in the audience for not getting to your questions. The last question is, why are there not more Melindas? What unique aspects of her condition and situation enabled such progress? And I mean, that's what I say every day. Why can't we just figure out why it worked for me and make it work for everyone?
Yeah, that's a tough one. So we are still actively, researching that question. I think we've got samples from Melinda. We've done some kind of advanced experiments on them, and we're still analyzing results because it's true. Like, this is a remarkable case. We know your T cells, I think they're somewhat special in terms of the way they target the tumors. They're derived from a CD4 T cell. We didn't get into that today. There's different flavors of T cells. Most people focus on CD8 killer T cells, but Melinda's was a CD4 T cell. But there are kind of nuanced properties of these CD4 T cells that we're still trying to understand. So I think it's more to come on that. We're still doing research.
Just to add a little bit to this, as technology evolves, also we're having new tools to study your case, Melinda, with spatial transcriptomics, so the sequencing at the cellular resolution on paraffin embedded tissue, and so the investigation may be just starting really to answer that question.
Well, good, because you know that I have volunteered any blood, tissue, whatever you need, it's all yours. Let's just figure it out. I cannot thank you both enough for being here again on World Cholangiocarcinoma Day and helping us to bring awareness to this disease, and for the work that you're doing to help all cancers. We appreciate it so very much. And again, to everyone who we didn't get to your questions, we will get them emailed to Dr. Tran and Dr. Turcotte and get those answered to the best of our ability. And everyone have go light it green somewhere and bring awareness to cholangiocarcinoma, and send us your pictures. And Dr. Turcotte and Dr. Tran, thank you so much, and have a wonderful rest of your day.
Thank you.
Likewise, thank you very much.